I'm going to go ahead and start some introductions. So again, welcome to the October CIS or Clinical Immunology Society webinar. Today we have a case by Dr. Sati, is what he goes by at Seattle Children's. He's one of our first year allergy and immunology fellows. I'm Lauren Gunderman. I'm one of the faculty members at Seattle Children's and University of Washington as well, assistant professor. And then our expert for today is Dr. Krista Zerby, who is at the NIH and who's a senior clinician there. And so we're excited to have her join us as well. And just a reminder for next month's session, so we'll have a little bit of a change in November for a joint case with the Histiocyte Society, and this will be a case during the day, so keep an eye out for that in your email. And there's actually already an invite in the previous invite for October if you wanted to go ahead and register for that, but the time and some confirmation of that will be coming. And I think with that, I'm going to go ahead and let Dr. Sati get started. And Sati, go ahead and take it away, and you can start telling us about this case. And we'll have some pauses throughout for looking for some engagement from the crowd.
Yeah, thanks, Lauren. Yeah, and thank you to CIS and for the opportunity to present this case, and thanks to everyone for joining. And today I'll be speaking about an interesting case. I'm a new fellow at Seattle Children's, so it's an interesting case that's evolved since I started fellowship here. I'm about a young infant with mycobacterial infection, and I'll try to touch on sort of how inflammation has maybe had both a positive effect on her course and maybe also a negative effect at certain times, and just how her case has evolved. Uh, so, so with that, I'll start with the case. So this is a 9-month-old female who initially presented with splenomegaly. And before that, I'll just say she was born a term. She really had an uncomplicated pregnancy and delivery. And before presenting at 9 months, she had been doing very well. She was healthy. She had been developing appropriately, meeting all milestones and growing well. She was at the 50th percentile for weight. Yeah, she presented at 9 months. And just to give some context for the initial presentation, in the week leading up to the presentation, she had some URI symptoms, nasal congestion, a low-grade fever of 99 degrees. But that had actually resolved over that week. But because mom described her as having sort of low energy throughout that week and not being as playful and active, the family took her to the pediatrician's office. At the pediatrician's office, right away, there was concern from the family that maybe she had some constipation with a firm abdomen, but the pediatrician recognized it was actually an enlarged spleen. And at the office there as well, they found her to be hypoxemic, and that she was promptly referred to the ER. So in the ER, she was actually not hypoxemic in the ER and did not require supplemental oxygen. She was tachypnic there, but comfortably so. And her initial labs were really most striking for profound anemia. Her hemoglobin was 3.3, as you can see. And then she also had notable thrombocytopenia with a platelet count of 39. Her white count was not low, it was elevated at 20, and her ANC was 10. And then I'm not showing her chemistry, but it was at least her basic metabolic panel was normal, with normal renal function, normal electrolytes, and her hepatic function panel was notable for a low albumin, an elevated bilirubin, and then normal aminotransferases and alk phos. Her lung exam, at least, and I should say she was initially presented to an outside hospital, and at least it was noted her lung exam was notable in that she was largely clear on exam. Her chest X-ray did show some central peribronchial thickening, and I'll show some images shortly. And given the splenomegaly, she got an abdominal ultrasound as well, which confirmed splenomegaly, as well as lymphadenopathy adjacent to the liver. So at that point, she was, of course, admitted to the hospital, to the ICU with that degree of anemia, and she was slowly transfused with packed red blood cells. On call, so that there, this might be a good point saying to see if there is a differential. I think it's relatively open-ended and she's relatively undifferentiated at this point, but I'm welcome to sort of take any suggestions. As you can see, several subspecialties were consulted. And maybe I'll pause and if there's anything in the chat that I can't see, I'm happy to take any questions.
Yeah, you can pause. So right now there's nothing yet, but so we have an infant 9 months old coming in previously healthy, but now with hepatosplenomegaly, respiratory distress, and with significant anemia and thrombocytopenia. I guess, do you want the audience to ask questions as well? Anything they'd want to know?
Yeah, sure. I mean, sure. Yeah, that sounds good.
Okay, either anything you want to know or any thoughts at this point. And if nothing comes in, we might need some more information.
Yeah. And while people are thinking, I'll just show this. This was a CT scan that she ultimately got that shows sort of the degree of hepatosplenomegaly she has with a very enlarged liver and her spleen as well. I think if to maybe fuel some ideas, I think, of course, she's quite
Well, hold on
undifferentiated at
one
this
second.
point.
Hold on,
Oh, go
don't give
ahead.
it up yet. So we have a, question of HLH markers and then her
Yeah, great
ferritin.
question. What was the second part, Lauren? Sorry.
Ooh, hold on, I think I froze. There we go. Sorry, what did you say, Dr. or
In
Sadly?
terms of HLH markers, um,
I think you're breaking up just a little bit. Uh,
her ferritin was normal at this time.
um, you might need to log back in and out just so we can hear you a little bit better. But it sounds like so ferritin was normal at this point. There's some question of primary HLH from the chat. And then
So,
some other questions about feeders, weight loss, lymphadenopathy on exam. And then Sati will jump back in here in 1 second. But as he noted, at this point, things were okay in terms of the labs. She hadn't had any weight loss at this point. She was febrile, and then no external lymphadenopathy or things on imaging, which we'll go into a little bit more.
I think one of the things you have to think about in an approach to a case like this is, she's 9 months, so she's made it 9 months and has been otherwise healthy. And then I think you can't ignore the hepatosplenomegaly. And I don't think you can ignore the classic pediatric questions of family history, siblings, new medications. I mean, a white count and a platelet count like that is should be like bing, bing, bing in terms of setting off red flags. But I think otherwise, you think, oh, it's a cold, they have a white count, but the platelet count and the hepatosplenomegaly has got to make you think about other things. And the fact, oh, and the other question that you always want to think about, and I know you guys are in Seattle, but you want to ask, what is the family ethnic origin? Where was she born? Parents' relationship to each other, things like that.
Great.
is my connection a little better now? Sorry about that. Thank you for jumping in.
Yes, it sounds great. And actually, you flashed up the other slide for a second. So why don't you go ahead and move there and we can go ahead and move
Sorry about
on.
that. And the other
It's
slide
okay.
does reveal something. So, but yeah, excellent discussion. HLH was definitely a consideration early on, but at this point there weren't sort of striking features of hyperinflammation yet, at least based on the ferritin level. And then other inflammatory markers were still not blazing high at this point. Thank you. Yeah, so the reason sort of, as I mentioned, as you saw in the last slide, oncology, infectious disease were both appropriately consulted. Immunology doesn't always get consulted this early in the case, but Dr. Gunderman had actually been following several members of this family prior to this patient's presentation. And as you can see from her family pedigree, both two older sisters of our patient had a mutation in the interferon gamma receptor 1 gene, and their father also had the same mutation. And so our patient had actually already had genetic sequencing at 3 months of age, well before her presentation. And as you can see, there was a four base pair, and this is our patient's genetic testing. There was a four base pair deletion in what's exon 6 of this gene, which results in a premature stop codon in the cytoplasmic domain of this protein. This is a heterozygous mutation, so only one copy is affected, but this is a pathogenic variant known to be associated with what we'll talk about, which is known as autosomal dominant interferon gamma receptor 1 deficiency. So just to provide a little bit of context about this disease as it evolves, as our case evolves, this is a form of Mendelian susceptibility to mycobacterial disease, or MSMD, and that's due to defective interferon signaling through the interferon gamma receptor 1 chain or receptor. It's an interesting disease because the autosomal recessive form, when you have two copies that are both dysfunctional, results in no functional interferon receptors, and most of those mutations occur in the extracellular part of the protein. So interferon can't bind at all and doesn't signal at all. In these patients with autosomal dominant disease, one copy is typically normal, and you can see the full protein here shown in this cartoon, with an extracellular domain, a transmembrane domain, and then an intracellular domain. In the mutated copy, most commonly the extracellular component of the protein is normal and can still bind to interferon. And the transmembrane domain is also usually normal. But the cytoplasmic domain, due to that premature stop codon, it terminates prematurely and does not allow for JAK-STAT signaling or induction of interferon-stimulated genes. So in a normal cell, in a normal patient with two wild-type copies, usually you have expression of a normal amount of interferon receptor on the cell surface. But what happens in this autosomal dominant form is that there's many copies of the mutated version that are expressed more so than the wild-type copy. And these mutated copies actually compete for and outcompete the few functional copies the patient has for interferon. And this is known as a dominant negative disease because the pathogenic mutation results in a pathogenic protein that's then interfering with the functional copy. That being said, as I'll show some data for, autosomal dominant disease, because they still have some residual interferon signaling, it's thought these patients have been shown to present typically later in life and with less severe disease presentation compared to the autosomal recessive disease. And I should mention this paper is from some of the earlier work that really described and characterized autosomal dominant disease. And then a follow-up paper that was also seminal to this work looked at dozens of patients with both recessive and dominant forms of disease and actually looked at their PBMCs in vitro to see whether they could signal through the interferon receptor. In looking at sort of TNF production or activation of STAT1 on the right, you can see that in recessive patients, there's very little activation and signaling through interferon receptor compared to healthy controls, especially. In the middle, you can see that as you uptitrate the amount of interferon in the assay, you can actually induce some STAT1 signaling and, in a way, overcome the defect. So that has actually led to the clinical use of exogenous interferon gamma in autosomal dominant patients. And then the only other thing I'll mention before coming back to the case is that this study also showed data that spoke to what I was mentioning earlier, where patients with recessive disease both acquire mycobacterial disease earlier in life, as shown in the yellow line here, compared to dominant disease, as shown in blue. And then these patients have, at least in the early 2000s, had worse outcomes compared to the dominant form of the disease. So I just want to highlight that point with this family. There's significant variation in the presentation of this disease as this family exhibits well. Dr. Gunderman can speak to this as well because she has been following these patients for many years. But the father had made it through 4 decades of life, and survived without really recognizing this diagnosis. He did have a history of potential bone cancer, which in hindsight may have been granulomatous disease or osteomyelitis. And then two older sisters both also had non-tuberculosis mycobacterial infections, but were never hospitalized and certainly never had the degree of um, anemia or thrombocytopenia or severe presentation that our patient developed. So I think it just highlights that there can be a significant variation of severity and onset of disease with the exact same mutation in the same family.
Thanks, Sati. And can you go back to that for a second? I
Yeah,
can
of
talk on that and
course.
then answer one of the questions in the chat about prophylaxis for the infant. So before I answer that one, what's very interesting about this pedigree is we only met the family in the last year. And so the first one to get diagnosed was the 2-year-old. And from the 2-year-old's diagnosis, the 40-year-old, the dad, the history kind of started making a little bit more sense, but he never had clarified mycobacterial disease, just kind of like granulomatous, dead, like no identified infection. So in hindsight, so diagnosed at 40, and then after the diagnosis of those, had all 5 of dad's children tested with the 8-year-old, and then the baby diagnosed. So at that point, everybody was kind of like placed on prophylaxis, evaluated for infection, that kind of thing, except for the little one. I think part of that was hesitancy on the family's part a little bit because of her age and just how little she was and how the other ones had done overall okay. I think in hindsight, and especially seeing how severe these little ones have presented, I would definitely push that. Just because I think that what you hear and you think about this disease that presents later, it's not going to be as severe, that kind of thing. And that's not the case in our patient. And so feel like kind of gives a good example of like definitely putting on the pressure with shared decision making, knowing how these cases can turn out. So no, she was not on any prophylaxis before her infection. And neither were the other ones because they were just identified after the 2-year-old's infections. But they're now all on azithromycin, and then the 2-year-old has been on interferon gamma kind of following her infection. Okay, Sachi, you can go ahead and move on.
Yeah. Sorry, I'm just saying some chat questions that I think going back to one, maybe you guys addressed this, but there were no fevers, weight loss, or lymphadenopathy. Lymphadenopathy is a little bit questionable. There's certainly hepatosplenomegaly, but no fevers or weight loss prior to presentation or on presentation. And thank you, Lauren, for sort of addressing that. What happened to our patient? So she, given sort of the history of, especially of her two sisters who both had non-tuberculosis mycobacterial infections, and her known susceptibility to mycobacterial infections, she was empirically started on an anti-mycobacterial regimen, and you can see it there. Shortly thereafter, Mycobacterium avium complex, was detected by several ways. First, by blood-based Karius testing, and then gastric aspirate as a surrogate for pulmonary infection, and then the bone marrow biopsy also revealed acid fast bacilli. So at that point, we had a reasonable diagnosis of disseminated MAC in a patient with interferon gamma receptor 1 deficiency. She was started on an antimycobacterial regimen. There was expectation that she was going to gradually improve. However, over the subsequent 2 weeks, again at an outside hospital, she actually showed several signs of worsening. She then developed recurrent fevers, worsening hepatosplenomegaly, and then her anemia and thrombocytopenia really did not improve. She required multiple transfusions over that 2-week period. And then ultimately, due to worsening respiratory symptoms with worsening tachypnea, worsening signs of work of breathing, and then worsening chest x-rays that showed opacification of the left lung, that prompted sort of additional workup. That came in the form of a chest CT. And you can see this shows 2 different cross sections of that same CT. And this is at like the 2-week mark after starting that anti-mycobacterial regimen. And what you can notice really on the right image is that the left mainstem bronchus is significantly obstructed by both a left upper lobe consolidation, and then likely as well, you can see there's a lot of hilar lymphadenopathy and mediastinal lymphadenopathy, or at least consolidations, which were suspected to be lymphadenopathy. Um, this this was, she also had a bronchoscopy at about the same time, and it confirmed that finding of significant obstruction in the left mainstem bronchus with severe inflammation and severe friability. There's a lot of mucus there as well. And she really did not tolerate this procedure well, and ultimately required epinephrine boluses. And she was on room air prior to this procedure and then required ventilation following it. And at that point, her antimycobacterial regimen was broadened further with the addition of amikacin, and she was transferred to our institution. So here, with the help of both, so we immediately got sort of a large workup, and some of these labs we actually had because we had requested the outside hospital to obtain them. But on arrival, she remained anemic and thrombocytopenic, largely supported by transfusions at the other hospital. But we then evaluated her for sort of signs of inflammation as well. And her ferritin at our institution was 4,200. And then this lab was very helpful in sort of confirming her diagnosis and it was ordered by the outside hospital, and her soluble IL-2 receptor, typically a marker of T cell activation, was 75,000, which was quite elevated. Interestingly, her interferon gamma level was elevated, but maybe not as markedly as I might have expected at 17.9. And her CXCL9, a marker of interferon stimulation, was normal. And then several of these other labs came back in subsequent days, but she had signs of other inflammatory cytokines in the form of TNF alpha, IL-2, and then innate type cytokines like IL-6 and IL-18, as well as IL-10. Her triglycerides were also elevated. And I think the audience, well, I can maybe pause. I think the audience was already there before I even got here at the first presentation, but were there any concerns at this point?
What do we think's going on? Anyone want to put it in the chat? HLH, we have
There you
it.
go.
Yeah, I think so
So
she didn't initially have, all of these signs. It was really with that clinical worsening. Although I guess we didn't really have these labs right on presentation, so I don't know what they would have been initially.
yeah, her ferritin was normal on presentation. I can say that, and her
That's
triglycerides were
right.
also normal, but we did not have the cytokines, at least. Yeah.
And we have a question about any culture results from the bronch.
Yeah, so the bronch at that point had shown AFB positivity, but the Mycobacterium avium complex diagnosis came from the Carius testing, and actually, so far, the cultures have not confirmed that until recently. At this point, they had not confirmed Mycobacterium avium complex, but the Carius testing was what had directed or had informed that diagnosis. Yeah, and we do not have any sensitivities at this point, if
Well,
that's
they
also.
actually just came back as of yesterday.
Yeah, yeah, yeah.
And I Oh,
Or,
oh,
but
sorry. Oh, sorry.
at this point in the case, we do not.
Rewind,
Yeah,
rewind. At this point, we don't have. Sorry, go ahead, Sonny.
yeah. Um, And then, but yeah, so just to sort of review this HLH criteria, she met 6 out of 7 of the criteria for HLH, with the exception of hemophagocytosis. So you guys are spot on. And, I don't want to belabor or, review HLH too much, but I do think this patient, given her inborn error of immunity, highlights maybe uh, some interesting facets of how we think about the pathobiology of HLH. So, typically we think about HLH as being an uncontrolled activation of CD8 T cells that can come from, either failure to eliminate a target or inflammasome activation. And, most people would say that's driven primarily by interferon gamma, which ultimately leads to activation of macrophages and then upregulation of more innate type cytokines. This was a nice review from Scott Cannon and Rebecca Marsh that shows that these two cells, usually there's a disconnect between your T cells and your macrophages that results in this sort of vicious cycle that can lead to pro-inflammation. Interferon gamma receptor 1 deficiency is not a particularly a gene or defect particularly associated with HLH. And it's interesting because it would suggest that her macrophages are actually unable to or defective in their response to interferon. But our patient still showed, significant signs of hyperinflammation. So I think her case informs maybe, some alternative pathways to get to hyperinflammation and even an HLH-like picture, either independent of interferon gamma or with other contributory cytokines.
And
Uh,
Sachi, there's a question in the chat about from Jessica. So, do you expect the initial severity of the hepatosplenomegaly and cytopenias from MAC alone, or the initial presentation to the outside hospital?
Yeah, so I think yes, so absolutely her initial hepatosplenomegaly was I would attribute to MAC at the initial presentation at the outside hospital, but it did show progressive worsening even despite antimicrobacterial agents. So I don't know this, but I suspect that the worsening of her hepatosplenomegaly was caused by HLH ultimately. And it's a good point. I think some of these symptoms you could argue are from the disseminated MAC, uh, like maybe the splenomegaly, but I would argue that that did worsen despite antibiotics. Um, and then, her cytopenias, you could also argue is from the MAC due to bone marrow involvement. But maybe I'll also see what Dr. Gunderman and Dr. Zerby think.
I agree. I mean, I think just clinically, we didn't have other features of HLH at that point, except for I guess she did have cytopenias, but then also had, involvement of her MAC in other areas of the body that were leading to cytopenias. So I feel like that worsening that we saw was maybe when she ended up presenting to us locally. And then, Krista, any thoughts?
Yeah, I mean, I think it's always never straightforward or as simple as it seems. I think it's well described from both the recessives and the dominants that when they're sick, they get hepatosplenomegaly. And I think that makes their cytopenias more complicated because I think there's both an element then of sequestration and you wonder, and without a marrow itself showing that there are organisms there, it's hard to know, but oftentimes, they do have marrow involvement, and so that changes their ability to produce, and then they sequester, and then they get into these sort of inflammatory milieu. So it's very complicated, but I think, and I'll talk a little bit about this, and I know Joe Rocco's on the call, but I would argue that all HLH isn't as straightforward as what people say it is, which is it's not always associated with just excess interferon gamma, but we'll get to that later. But I think I would agree with all of that. I think it is complicated. It's likely to be multifactorial, and clearly she was infected. Whether or not you could find it is a different matter, but I mean, that lung is not a lung of a healthy, uninfected kid.
Thank you. And there's one more, just I guess kind of a comment slash question in the chat, but did she have fevers all along, or did that occur later? And then just the kind of the thought about maybe the new fever was a transition from infection to HLH.
Yeah, so yeah, I agree with that comment. She did not have fevers prior to presentation. She developed recurrent fevers during the hospitalization after antibiotics, and I think that was the first sign or one of the major signs of HLH or hyperinflammation at least. Um, and then So there is some precedence for this, and there's 5 reported cases in the literature of HLH and interferon gamma receptor deficiency. Um, one in an autosomal dominant patient, and so this outlines sort of some interesting details about those patients. The autosomal dominant patient is in the middle here. All 5 of those patients had a mycobacterial infection and or a reactivation of their BCG vaccine. Interestingly, 3 of those patients had concurrent herpes virus infections, and they all received sort of different HLH-directed therapies. or immunosuppressive directed therapies with different results. Um, and then and that, yeah, so it can happen, and I'm interested in maybe hear some of the discussion towards the end about the alternative mechanisms. Uh, and I think that's maybe a good pause point just to see what would people do at this point. I think maybe I've suggested that there's some convincing evidence of hyperinflammation. There was a lot of discussion because I think the other thing that was on the differential was, well, does she just have a very untreated or poorly treated MAC infection? And do we need to be more aggressive and actually give interferon gamma? Do we need to broaden our antibiotics further? Or do we need to immunosuppress her? Knowing that immunosuppression, decreasing inflammation will make it more difficult for her to clear this infection on her own. So I'll show what we did, but I'd be curious to know if people had thoughts on any or all of those options. Yeah.
Yeah, feel free to put in the chat if you have any thoughts about things you would do. Sati kind of outlined our division's discussions at this point, since it was kind of you know, a rough decision of what you do in an actively infected patient like this. It might be a stumper question, so you might just need to show us what we did.
Wow. Okay. Um, oh,
Oh, hold on, you got one comment. So you could try to dampen with anakinra, which won't impair infectious clearance, but will probably need stronger like Rux.
yeah.
Great.
Perfect. Yeah, that's a great segue. So we did, yeah, so that's a great comment. So we did start anakinra. It started on arrival, and I'll show you sort of the response to that. We heavily discussed ruxolitinib, which I can also talk about. Just before getting there, moxifloxacin was also added in collaboration with our infectious disease team. And so this is ultimately the regimen she was on for quite a long duration. And so those were kind of done concurrently. So moxifloxacin was added, and amikacin and moxifloxacin were both added about at the same time, as well as anakinra. Fevers resolved essentially immediately. She did not fever after starting anakinra and adding those two antibiotics. And then bone marrow function gradually recovered, and thrombocytopenia resolved. Her hemoglobin is uptrending, and her hepatosplenomegaly has shown some improvement, but it's certainly not normal by any means at this point. And then this just shows sort of some of those inflammatory markers that we were tracking, and soluble IL-2 receptor in red, and ferritin in black, and sort of immediately after starting anakinra, those both significantly declined, though they have not normalized, and anakinra has been continued for at least a month. And then ruxolitinib was strongly considered, but because she did demonstrate a reasonable response and overall improvement in all of her markers with just anakinra, as well as the addition of those antibiotics, we held off ultimately, but we did consider it.
The response to anakinra was noted to be beautiful in the chat.
Perfect. Yeah. So I'll just touch on a couple takeaways, and actually I will give a little bit of an update on our current clinical course, and leave a couple more discussion questions. So I think for me, two major takeaways, from reading about autosomal dominant versus autosomal recessive disease. I think it's a reminder that autosomal dominant disease can have a lot of variability in its presentation. And even though the median onset is later overall compared to autosomal recessive disease, there can be variability. And like Dr. Gunn was saying, it's maybe it warrants strong consideration to start prophylaxis in these patients, even though they maybe they don't always develop severe disease. And then this disease process, there's a number of case reports I showed you, this case as well, where this disease process can lead to a hyperinflammation situation, HLH-like or HLH. And I think it's sort of the conversation that has come out of this over the last several weeks is sort of how do we balance her need for some degree of inflammation to clear this infection with the need to control inflammation or even dampen our immune response. And ultimately, how is this best going to protect her from the deleterious effects of hyperinflammation and allow her to clear her infection. So I think on that last point, I'll just give a couple other updates. So I think her HLH, I showed you some data that her hyperinflammation or HLH improved, arguably resolved. But around the time she was extubated and around the time of extubation, she was started on steroids and to help aid with extubation. And she turned out to require, she had a lot of signs of lower airway obstruction. And every time the steroids were weaned, she developed respiratory worsening. So she's sort of ended up stuck on chronic steroids at this point for several weeks. And then I think the other thing that's emerged in the last 3 weeks is that a blood culture drawn 2 weeks after arrival ended up coming positive for AFB. And this is at 2 weeks into that broadened antimicrobacterial regimen and 2 weeks after anakinra initiation. And interestingly, blood cultures before that have all remained negative. So there was concern maybe that her disease was actually worsening, even though her inflammation had improved. So a chest CT was a repeat chest CT was obtained, and there are some signs that there's progression of her pulmonary disease. She continues to have significant obstruction of the left airway. The left upper lobe consolidation is worse, and she has new and progressive tree and bud nodularity, and ultimately the radiologist read it as progressive worsening. So I think with that, maybe I think two questions that have sort of been ongoing for this patient are, fresh off the heels of hyperinflammation, would you start exogenous interferon gamma, or when would you start that to help her clear this infection potentially? And would you, maybe a more sort of long-term question that is more, not something we're considering now, but would you ultimately consider transplant in this patient? And just for context, autosomal recessive patients typically move towards transplant, whereas autosomal dominant patients, because of their mild form or thought to be milder form of the disease, typically it's much more rare to transplant those patients. So those are two, I think interesting maybe discussion questions I'll leave, but I'll open it up to Dr. Lauren and Krista to sort of also weigh in. And thank you again for the opportunity to present. Sorry for the technical difficulties.
Before we get to those, there was one question about PCRs. I'm not sure which PCRs, but that came up with the asking if we had done them. We do have viral PCRs that were negative previously, if that was the question. And then I think the other one was kind of what's the experience, your same question of like, what's the experience with treating patients with interferon gamma when infection is under control? That was kind of the question. So I think that's what Sati is kind of asking here is, when's the best time? Should patients that are clinically improving apart from obstruction be started on these things? These are conversations we've had. Oh, okay, sputum PCR was the question.
Yeah, as far as I know, we have not sent a sputum PCR. I assume for Mycobacterium, which you're asking. Actually we don't have sputum from this patient, but we do have BAL, and we haven't sent. I don't believe that's been sent either.
I think it might have been,
maybe it was.
maybe it wasn't sent for PCR, but for culture. I'm not 100% sure on that either, but the AFB sputum, like BAL was sent, but sorry, from the NG2. They had some gastric aspirates at the other hospital that I think are maybe still in process. Sorry, just reading from the chat. So we may have that information either in process or returning at this point. And then, yeah, any thoughts about the interferon gamma from the crowd or Krista, if you wanted to comment at all on that. And then there's another comment about BCG is very common too, especially in countries where this vaccine is given. Yes, I think it's very different, the experience. It would be nice to hear more about, experience in places where BCG isn't given, because I think the case's severity tends to be a little bit different. That's why I think these patients can be a little bit more tricky and challenging when they present later. In like, this area, these patients are from Alaska versus earlier on with BCG. I'll stop talking now, Krista, go ahead.
Oh, so I think so. I just have a couple slides if it's okay.
Yeah, of course.
Okay, so let's see. I'm gonna replace. Oop, there it goes. All right, hold on. Replace current share, and then I'm just gonna share my desktop. I'm always well. Hold on, maybe I can do this. Let's try that. I'm always nervous about what happens if I share my desktop. What pops up? Okay, so I just I think in general with these types of patients, whenever you see disseminated mycobacterial disease outside of HIV, of course, you always want to think about the interferon gamma pathway and all these organisms have been associated with interferon gamma receptor deficient patients, both autosomal dominant and the recessives. And specifically in countries where we've seen salmonella both here and where there's countries that it's more common, and of course histoplasmosis. I would say the autosomal dominants tend to have, excuse me, a lot of axial involvement and can be quite dramatic. And I know there's several in the literature of bony disease that sort of erupts out. I would agree. I think it's hard to know whether, she has such constriction of her airways, whether that's all from adenopathy or, compressing and she is post-obstructive pneumonia there, or whether or not that's truly mycobacterial disease. The rest of it certainly looks like mycobacteria. That second CT you showed was quite dramatic. I just want to remind people that here is the receptor recycling domain, which is oftentimes where you see the autosomal dominant form. So the interferon receptor doesn't recycle appropriately. I think the question of to transplant or not to transplant, I'm trying not to, I don't want to do like anything formal here, but I just wanted to sort of go over one of the cases in which we did transplant successfully. And I think in the setting of what we know more and more about HLH and inflammation and excess interferon gamma, transplantation can be safer or more successful when we have drugs now like emapalumab and ruxolitinib that we can use. This is the case of the 58-year-old woman with interferon gamma R1. So she was diagnosed with her son. So her son died of disseminated X cluster. She was diagnosed and remained bacteremic and had wildly aggressive disease for decades of therapy. And her other son, who has never been infected, is also has the same mutation. She underwent a 10 out of 10 from a sibling donor. This was the regimen that they used. This was done in conjunction with the transplant folks here, Damana Dimitrova and Jennifer Kanakri. This was their GVHD prophylaxis, and she actually had successful engraftment. This was before we were routinely checking CXCL9. Her circulating interferon gamma was similar to your patient's, wasn't very high, and she was on multiple antibiotics. And we actually had her on exogenous interferon gamma, but she did not have that same sort of inflammatory flare that your 9-month-old had. Her liver and spleen were well into her pelvis at the time of transplant, and that was a big concern in terms of successful transplantation, because I think the issues of transplant in this population is not just the interferon gamma, but it is also their huge spleens and the concern about sequestration and successful engraftment. She had significant engraftment syndrome post transplant. I just want to show you some of her disease. So on the left is pre-transplant MRI, and on the right is a post-transplant. And you can see that her diffuse osteomyelitis resolved. This was her skin and the lymph nodes that really just extruded pus. She also had eroded the entire hard palate of her upper mouth from mycobacterial disease. But just to remind everyone that, and Sathi, you did such a great job. My effort here is very minimal compared to yours. But just when you think about this disease, doing flow for R1 can help differentiate in a sort of straightforward manner, differentiating the dominance from the autosomal recessives. Because you could either get a lot of interferon gamma. Remember, interferon gamma binds to its receptor. It gets internalized, the interferon degrades, and the R1 is then recycled to the cell surface. But in the autosomal dominant, oftentimes they have issues with the recycling, and so they have a lot of defective R1 on the surface, but it will occasionally bind with wild type and they can get successful signaling. And I wonder whether sometimes that's why it's not as high as you would expect, because they do get some normal signaling. But you can look for flow on the surface and it's really high. And of course, in the autosomal recessive, it's a no-brainer. They don't express at all. So they have zero, near zero. And the paper by Susan Dorman is a very nice example of the interferon gamma signaling. So, you know, the differences of them, you're right, but your patient was diagnosed early. And because she was sick, right? You had already tested her because she had a family history, but she got sick early on. So one of the things that you worry about, not just pre-transplant, but as post-transplant, and this patient is one of those patients. So the first two patients here are from a paper that Mara Mannion published in CID. And the first one is the patient that I just talked about. And the second one is a 6-year-old R1. And these are their CD4 T cells reacting to MAC in vitro. And this is TNF alpha is on the y-axis and interferon gamma is on the, well, sorry, not TNF gamma, but interferon gamma is on the x-axis. And this is, you know, a response pre-transplant. This is an IRIS, so immune reconstitution. So, and I think Joe would agree with me. I think no matter what you want to call it, immune reconstitution, cytokine release, engraftment syndrome, they're all sort of continuums of HLH. And then, of course, they get a whole bunch of medications to resolve it and things get better, but they don't go away completely. I would say my argument here is that it isn't just as about interferon gamma. And the reason I say this is we see HLH. If you take away the primary HLH genetic defects that we know about, you know, CGD patients, which is I'm a little biased, but you know, they get HLH and it's all secondary HLH, but CGD is not a, you know, a gammopathy. They know how to signal. They signal appropriately through the interferon gamma receptor. So why do they get HLH, right? So why doesn't everybody with interferon gamma R1 deficiency get HLH? You had a very nice case series there, but there's a lot more patients than that, and they don't all get HLH, and they all get infections. When you look at BCG, which is sort of the universal immunologic test at birth, and outside of this country, BCG and disseminated BCG occurs. And why are some, when you look at some interferon gamma R1s, their circulating interferon gamma isn't very high, and some of it is very high, or their CXCL9 is very high, and not everybody is as high. And then I will tell you that now we have a patient who had interferon gamma cytokine antibodies, and she had a very activated T cells, and for all the world looked just like HLH. So I think that it can't be as simple as it seems. And I think that lumping everybody into the same basket won't necessarily answer or direct our therapies as carefully as we want. And I think that's all I really wanted to say. But I think this is an absolutely great case. From my perspective, I think until you cool her off, I would not add exogenous interferon gamma. So we had a patient on 12R1 in whom we added interferon gamma, and she went like floridly into HLH. And then granted, it was correlative. I don't know if we can show causation. We have used interferon gamma exogenously in a lot of patients who are infected with a wide variety of intracellular organisms, histoplasmosis, mostly non-tuberculous mycobacteria. And we've done it safely, but we typically see how their inflammatory state is. Their hepatosplenomegaly doesn't bother me. The cytopenias don't even really bother me. It's the ferritin that bothers me, and your soluble IL-2, which would make me nervous about giving high doses of exogenous interferon gamma. And from an antimicrobial standpoint, you know, you could think about looking at some of his name just flew out of my head, but he's the guy who does all the dual beta lactam. So he gives meropenem to saturate your beta lactamase, or sorry, avibactam or you can even do clavulanate, although we can't do that alone in the US, followed by meropenem Q12. And you can use that in addition because you're using IVs anyway in terms of amikacin. You could think about, and I think knowing that the cytopenias might be improving, you could think of low-dose linezolid. I like linezolid a little bit better because you can dose reduce it, although for peds, you could obviously dose reduce the IV to Dazolid. But you can just use once a day low dose linezolid, which I think is quite good. And of course, there are other drugs which I don't know if they're as proven, omadacycline, bedaquiline. And again, I'm not a pediatrician, so I don't think that bedaquiline is okay in peds yet. I'm that young, but I'll leave that to the pediatricians in the audience. I think that's really the things that I wanted to add. I know that Joe is also online and may have something to say about the HLH.
I think just for a previous comment, well, I guess first, thank you, Krista. That was awesome and really helpful to go through. But something about, well, so Joe said it's all about the T cells. And had previously noted the beautiful response to anakinra. And then there was another comment about, the same thing about when things are cooled down to consider using interferon gamma would be a thought. And I will say in the more recent times, she has kind of cooled, like the inflammatory markers are much better, apart from obstruction up here. Things look at a better controlled point where maybe we would consider that. But definitely not when she came in, when she was so inflamed. I think that would have been a really bad time to use interferon gamma. Um, and then I don't see any other questions or thoughts. I guess, let's see. Oh, here's a question. So, was pre-implantation genetic diagnosis or prenatal diagnosis suggested before pregnancy of the first pregnancy? For this family, all of the kids had been born or were already ready to be born when the older sibling was born. So right now we don't have that. That has been something I've wanted to bring up to mom. However, she's still with the kid in the hospital right now and she's acutely ill, so we haven't talked about that. But that is something that I try to discuss with these families that aren't already, right near delivery or already have kids that are born. That's a great point. These big families. And then one other comment about agreeing about no interferon gamma until he's the soluble IL-2 or CD25 is much improved. I think we're about 15,000 now. He's suggesting less than 1,000. And then agree that since looking HLH-like, then probably buying herself a transplant, which would be a long course to clear the infection and then balancing the hyperinflammation. Yeah, I think that's going to be something that we'll consider going forward. It's definitely challenging. There are 5 other kids in the house. The family doesn't have a lot of resources, so I feel like that seems a little higher risk situation, but she, out of all the siblings, is one that I feel like could be considered for transplant. Any other thoughts from anyone? Questions, comments? Appreciate the discussion from everybody. This has been really, really great. Sati, awesome presentation and going through the pathways for the different interferon gammas. And Krista, thank you so much for your presentation and just expertise in this. And then I think anything else you want to share, Sati, before we let everyone go?
No, thanks to everyone for joining and participating.
I think this is a great case, and I think it exemplifies that, that not every patient presents the same with the same genetic diagnosis, and that it still remains lest AI take over all of our jobs, that they are different, and knowing what to look for and thinking of them as an individual, and looking how they present and not treating all of them because of their mutation, but actually using their mutation as a launching pad to how you approach the case is a wonderful take-home point that you were so good at pointing out, Sati. That was a great case.
Thank you guys. And thank you everyone for your participation. Don't forget to join us for the next webinar in November and have a good rest of your night.
Thanks so much.